I'm Benjamin Keller, and this is leveraging technology and evidence-based practices to create a culture of curiosity and continuous professional development in nurses as partial fulfillment for the course requirements for Nursing 512 Research and Evidence-Based Practice for CSU Pueblo. Today, we'll briefly cover an introduction and the PSCO question, a case study of Santa Maria Health, a fictional health system, quick look at literature review, gaps and limitations. We'll look at relevance and implications for the clinical nurse educator, and this will be covered throughout to keep things interesting. And then conclusion, references, evidence table, annotated bibliography, and so forth. So, introduction. Nurse engagement in evidence-based practices. The research shows that it improves care outcomes, patient satisfaction, nurse retention, and job satisfactions, and it decreases nursing errors and burnout. One example of evidence-based practices in nursing is HRO. But what do efforts like HRO, total quality management, root cause analysis, CPI, which is continuous process improvement, LHS, learning health systems, Six Sigma, and the like have to show? We've been looking at these different management styles for over 30 years, and we still only have 20% of our clinical decisions based on clinical evidence, and 80% of care is not based on evidence-based practice, but rather on outdated procedures, policies, and traditions. So how can we improve this? There's also been an explosion in medical knowledge, and that's important in continuing professional development. An example of this is in 1950s, the rate of medical knowledge doubled every 50 years. In 1980, it was every 7 years. By 2020, it's every 70 days. So that means every 70 days, the amount of information that we know in medicine and nursing has doubled. And this is a significant challenge for nurse educators to communicate because things are constantly changing and best practices are constantly changing and clinical practice guidelines are constantly changing to keep up. But we're not very good at it. Attempts to close the gap between research and practice has proved to be only partially successful at best, leading to the delivery of substandard care that's either superfluous, ineffective, inefficient, or inconsistent with practices elsewhere. We can do better. So some questions for the clinical nurse educator are: what barriers prevent evidence-based practices from happening at the bedside? Or what can increase the utilization of evidence-based practices for the individual nurse to make continuing education more effective and timelier? And so the PICO question that I came up with was, in bedside nurses, how do best practices and microlearning compare to traditional education approaches in the utilization of evidence-based practices? And you might be wondering, why microlearning? And we'll take a look at that in just a minute. So we're going to take a look at a case study here. It's a fictional case study of Santa Maria Health. I made it up, but it could be really anywhere. Santa Maria Health recently merged. It's an independent medical system. It has 3 safety net hospitals that came together to survive. Together they have 43 general medical beds, a 5-bed low-risk mom and baby unit, 2 level 4 emergency rooms, a small urgent care center. Unfortunately, though, layoffs by local employers and stagnant economic growth has been hammering the area. State representatives have chosen not to participate in Medicaid expansion, so there's no federal dollars there. And so their payee mix is now about 75% Medicare self-pay and charity write-offs. So they're struggling to get by. Some barriers at SMHS for the clinical educator to overcome include little incentive to change, recruiting difficulties. They can't compete with larger cities regarding nursing pay and benefits for new nurses that are trained in evidence-based practices. There's no money for capital improvements or new equipment or hiring outside consultants. And then there's just in general poor morale, in part because of the poor economic conditions in these small areas that they are serving. Some additional barriers: state regulators came in recently and cited them for increased CAUTIs, and utilization of evidence-based practices and clinical guidelines is only about 20%, which is on par for most other healthcare systems, according to the research. So how might the clinical nurse educator assist the administration in a situation like this? One strategy is to use Coulter's 8-step change model to identify thought leaders and change champions. They can leverage the evidence-based practice process to create a team to guide systemic changes. They can utilize blended and micro-learning, gamification, and just-in-time learning to reduce CAUTIs, and they can create a culture of curiosity that attracts and retains new nursing talent. And can they do this quickly and efficiently with a lack of working capital? And the answer is maybe. We're going to take a look at what the research shows, and then I'm going to come back to this case study and see how this case could be resolved utilizing what we know. So let's take a look at the literature review and gaps and limitations. Now, these are just some primary findings here. There is an annotated bibliography following the presentation, so I'm only going into a couple of articles for the sake of time, but I invite you to take a look at the annotated bibliography as well as the evidence table that's in the back. There's some pretty good studies that are out there in this. So the biggest takeaway is to create a culture of curiosity. Leo 2023 et al. Did a systematic review of 155 studies involving over 17,000 participants for nurses and nursing assistants in long-term care. 77% of those participants were nurses. And they had some key findings that included things like management style, that relational management style tended to increase satisfaction for employees, and it increased better patient outcomes. That peer support, coaching, and mentoring are necessary to utilize newly gained knowledge and put it into daily practice. So it wasn't enough to go to a seminar or to watch a video to learn something new. They needed to have coaching and mentoring at the bedside to help put that new knowledge into place. And management and institutional culture are required to support behavior change. That watching videos and doing seminars, it's not enough if that support is not present. And this is just one example of very similar findings that you'll see in the annotated bibliography. Kind of big idea number 2, and that's to blend learning modalities. Dual et al. In 2022 did a systematic review and a meta-analysis that examined 13 random control trials and 12 quasi-experimental studies representing 2,706 nursing students. And they had some key findings, and the primary thing was blending in-person and online teaching modalities yield better results regarding learning retention, knowledge retention, and satisfaction. It's greater than face-to-face only education, but that face-to-face only education, face-to-face education was also important. And then also, if you can blend these, it can be more cost-effective, it can be more flexible, and it can be timelier because you can have people watch these little bits of these online learning modules as needed and as they're available, so you don't have to have multiple classes at different times around scheduling, which can be very difficult for nurses. And then finally, the last idea here is micro-learning. And so Dugang in 2019 did a scoping review of 17 studies representing 2,228 health professional students, and they found that micro-learning positively affected knowledge retention and increased collaborative learning. Also, they looked at just-in-time learning, which provides immediate focused training for teaching new skills or reinforcing previously learned clinical skills. And that would be like a QR code that might be like a QR code that's next to the supplies for a cast, so it can teach you how to do a volar cast, for example. We use that in my own emergency. So gaps and limitations. One question, admittedly, it wasn't until this past week that I learned about evidence-based teaching and knowledge translation. And that's a different approach to research. And I'm wondering that if I had taken that approach to look at this in terms of evidence-based teaching and knowledge translation, how my results might have been different. They were still good results. There was a great amount of literature that I was able to come across, but it might have been a bit richer. Now let's take a look here at the relevance and implication with the clinical nurse educator and applying those key takeaways. So we can look at Coulter's 8-step change model, and this is how a clinical nursing educator might help overcome some of those barriers. And one is to create a sense of urgency for change, build a guiding team, create a vision and plan for change, communicate the change vision and plan with those key stakeholders, enable action by removing barriers to change, generate those short-term wins, build on change, and anchor the change in organizational culture. And then I use the evidence-based practice process in terms of asking questions, searching for the evidence, appraising evidence, integrating the evidence into practice, and evaluating the outcomes and sharing the results in order to encourage and support a spirit of inquiry. Let's see how that works in our case study. So the clinical nurse educator used Coulter and the evidence-based process to create that sense of urgency. They combined a 30-minute in-service highlighting the problem of CAUTI and the impact of patient outcomes on reimbursement. They shared the evidence-based practice guidelines, and then they had 3 5-minute long micro-learning videos on how to do catheter care, infection prevention, cleaning, and how to expediently remove catheters when they were no longer needed. And then they place QR code near the supplies and the break rooms for just-in-time learning on catheter care and cleaning. In addition, the clinical educator and administration shared real-time unit and hospital-specific data to enhance buy-in and create some friendly competition. They peer-nominated and self-selected evidence-based practice champions, and those champions attended an evidence-based practice course taught by the certified nursing educator, and they met monthly to explore other needed areas of evidence-based practice around the facility. After 3 months, they found a ripple effect and a culture shift. Additional departments joined the evidence-based practice group, including those from admissions, housekeeping, maintenance, and the hospital cafeterias. This led to decreased turnover, improved cost management, greater efficiency throughout the system in different departments, and improved morale. Let's quickly highlight those key strategies one more time. So it's essential to provide leadership support, adequate staffing, and compensated time for continuing education, to blend traditional online and micro-learning or short videos to enhance retention, to post QR codes for just-in-time training to provide reminders on evidence-based practice or clinical guidelines, and you can post these areas or post these codes in break areas, on equipment, or near supplies. You can utilize change theories or an evidence-based model that sells the problem, and use a dashboard that provides access to quickly consume content, like a 5-minute video from home, and tie that to the clinical ladder to help motivate those to be involved. And I'm just quickly going to flip through the reference slides here. Here's an annotated bibliography, and I invite you to pause this so you can take a look at these articles a little bit more closely. And here's the evidence table. Again, you can go through it at your own pace. Thank you so much.